I think we are live right now, right from the studio of Nextillo, and I welcome you all to the video of antipsychotic drugs. So, I won't be starting the live stream right away. I would like to wait for everyone to join so that it's easy for everyone to understand and go through the video, right? So, few things about Nextillo. We have launched a case series where I'll be doing a clinical case with integrated medicine. Um, it involves basics of physiology, pharmacology, pathology, and in that video, we have tried to integrate each and every aspect of medicine, including the paraclinical and the uh, basic basic subjects, including the physiology, biochemistry, and anatomy. So, those cases they are live right now on the YouTube channel of Nextillo. We released them yesterday, and the follow-up cases for that will be released in 48 hours. In the next 48 hours, for example, the first case was released yesterday, so the next case would be released the next 48 hours, and then once you have that, and in the next 48 hours, we would have another part of that clinical case. So it's a follow up of one clinical case. We would discuss multiple aspects of medicine so as to give you a complete understanding of a disease, including the lab values and physical examination, right? So that is about the clinical case series by Nextillo. So this video is about antipsychotic drugs. Mental health is important for all of us, and it is one of the most important disease that is being highlighted on not only on social media in regular day-to-day life, because when COVID hit, a lot of us were isolated and we had difficulty in managing ourselves, our emotions, and a lot of people fell victim to the mental illness, right? And my experience with mental illness is that I shadowed a physician overseas in United States. So he had wide variety of patients. um, the patients were from personality disorders, and then bipolar disorder, schizophrenia, major depressive disorder, and some people had some psychotic symptoms with major depressive disorder. So uh, this doctor, his name is Dr. Kasim. He used to do psychotherapy along with uh, prescribing medications to his patients. So it was a very enriching experience to see that it's not only the medications that make difference in people's life, it's therapy and making the patient understand what is psychiatric illness, because he used to talk about psychiatric illnesses in the form of that there are a number of factors. The first factor would be the environment. That environment includes the school environment, the family environment, right? And then he talks about genetics or family history, and then he would talk about the role of triggering events. Let's just say let's just say a stressor. In the recent reference, for example, COVID was a hit. COVID was a hit or the triggering event for a lot of people with mental disorders, right? So it's a combination of everything that produces major, maybe a lot of mental illnesses. Let's just say someone has major depressive disorder. The family environment, the school environment, then genetics, everything plays a role. And then there comes a stressor event where the person falls into the depression, right? And how many of you have joined till now? I want to see that. There are 9 people waiting in the room. Okay. So I'll wait for more people. I want at least 15 people to join me and in this discussion of antipsychotic drugs. So yes, mental illness. Initially it was stigmatized, but now there is less social stigma. But I wouldn't say the stigma has totally disappeared from the population. So I've seen people become much more aware about it, and I've seen people pursuing even uh, degrees related to psychology, right? And they are the ones who are doing therapy, and it's great to see that there is so much enthusiasm about mental illness right now. And yeah, that's about it. um, I would like to say that if you guys have any questions regarding the discussion about antipsychotic drugs, uh, post them in the chat box of this live, or you could put them in the comment section if you're watching later. We can answer those whenever we get the questions, right? We won't be answering them right away, but we'll take our time and get them back to you, right? So yes, we have currently 9 individuals still. So how is everyone? Is Friday treating everyone well? Okay, so we have 11 people with us. Okay, so does anyone amongst you have had any experience with mental illness? My experience was with someone who was a psychiatrist himself, and I shadowed him, right? So have anyone of you have had the experience, be it be a family member, right? How was it? How did you deal with it? If you're I mean, if you're comfortable enough to share that, that's okay. If you don't want to share, that's okay too, right? So yes, I think we should start, and let's begin with antipsychotic drugs. So the word antipsychotic, right? So the word psychotic is important. Now, psychotic is derived from the word psychosis. Now, psychosis contains a number of disorders characterized by delusions, hallucinations, so delusions and hallucinations are part of psychosis, and which can be seen in a number of disorders. Amongst these two, the most common being schizophrenia. And the second one that we want to concentrate right now is bipolar disorder. Okay, let's see what is happening in schizophrenia. So in schizophrenia, you have delusions, you have hallucinations. So amongst everyone who's listening right now, can anyone tell me in the comment section what is a delusion? I'll wait for about 15 seconds, maybe 20 seconds, right? So can anyone tell me what is a delusion? Waiting. I think I should get a response. It's okay even if you don't know it. So yes, Anmol Singh, that is right. That is right. Having false beliefs is a delusion. So what is an example of a false belief? Let's just say if you're a guy or a girl, maybe you believe that aliens are sending messages to you, right? Another example could be a virus is being put inside your body. So that is a false belief. In reality, it's not there. So that is a delusion. Now, what is a hallucination? So hallucination is something that you see, hear, or smell, but it's not there. So let's just say somebody is saying that they are hearing the alien is communicating a message to kill someone in their family. So this is what is happening. This is what happens in patients with psychiatric disorders, that they could hear things which could harm them, or also the person who are with them, maybe family members, right, their friend, or even their partner. So that is why knowing about psychiatric disorders is so important, because they don't have insight into it. So if you see things, you see a demon, right, or you hear a message, or you smell something. Let's just say you say that you're experiencing rotten egg smell, despite your room having multiple fragrances, multiple room air fresheners, and and the person who's suffering from schizophrenia could say to you that they are experiencing as if the rotten smell is in the room. Now, in schizophrenia, you can also have catatonia. You can also have catatonia. So, what is catatonia? It's just the abnormal body posturing. Now, I relate it to a cat because whenever you when you try to lift a cat, it makes a particular posture like this, right? So I relate catatonia to a cat being held by a human. So there could be other symptoms of schizophrenia. So what are these? These could be negative symptoms, which include social withdrawal. Now, after social withdrawal, there could be lack of motivation. And then you could have loss of interest in your daily activities or hobbies, and you would find these patients ill kept, not bathing, not taking care of themselves. Yes, that can happen in schizophrenia. So psychosis can also be studied in bipolar disorder. So in bipolar disorder, you have mania and depression. Now, why does it why do we call it bipolar? Because there are two poles. One is mania, the other is depression. Now, for mania, we have a mnemonic so that we remember what does mania do to a person. So it's called dig fast. In mania, the person becomes fast. So there is, from D, distractibility. You can easily distract the person. Now, and then from I we have so we can move it to the next one, G, that is grandiosity. For F we have flight of ideas. Okay, and then from A we have agitation. And then from S we have sleep. And the last one is talkativeness. Now, distractibility. So the patients with mania can be distractible, right? They can be grandiose. Now, for grandiosity, they could believe that they are a secret agent. Or they could be working for the government. So this is a delusion. And then flight of ideas. So for flight of ideas, what do you have? It could mean that they could put some money and get a lottery out of it, which is obviously not possible, but they would start believing that idea. Or they could have another idea that they could rob a bank, maybe, right? And then agitation. So if you talk to them, they would get easily agitated. And then sleep. Patients with mania, they have decreased amount of sleep. Let's just say a typical person is having 6 to 8 hours of sleep per day. Then person with mania, they would have less than maybe 1 hour a day. And then talkativeness, they would talk excessively and with pressure. Now we have intentionally left out the I. So the I is irritability. So irritability could be part of anything, but yes, it is part of the diagnostic criteria for mania. Now there is something called hypomania. And how would you differentiate mania from hypomania? So let's just say someone who's having symptoms of dig fast, if they require hospitalization, it's mania. Or if the symptoms last for 1 week, it's called mania. Right? Now, if it doesn't require hospitalization and the symptom lasts for 4 days, but less than 1 week, that is hypomania. Right? Now that we have discussed the major disorders with psychosis, we would move towards what are the chemicals in the brain which would cause psychosis. Now when the initial research was done, they came up with dopamine. So they found out that any patient who was suffering from schizophrenia, they would have increased number of dopamine receptors and dopamine levels in certain areas of brain. So increased dopamine in the brain, and when they developed drugs which were antagonizing the action of dopamine, they found that the symptoms, they improved. Okay, now there are 5 important pathways of dopamine in the CNS, and we will concentrate on 3 in this live YouTube live. So the first one is let's zoom in. First one is mesocortical or mesolimbic. The second one is nigrostriatal. And then we have a last one called tuberoinfundibular. The first one, that is mesocortical and mesolimbic. This pathway is from the ventral tegmental area to the neocortex and the limbic system. And the research found out that this area or this connection is related to behavior and psychosis. Right? So we would target this area for most drugs who are treating the psychosis or the psychotic disorders. So what would happen to the next two? So the nigrostriatal pathway, where the substantia nigra connects with the striatum. Here the degeneration of neurons leads to Parkinson's disease. Right? So this area is related to Parkinson's. And then the third pathway is tuberoinfundibular. Now this pathway is between the arcade nuclei and the periventral nuclei towards the portal system of the anterior pituitary. So here the dopamine regulates prolactin release. Studying nigrostriatal pathway and tuberoinfundibulus pathway is important because these two pathways, they become important when we are antagonizing dopamine, because the antipsychotics could produce inhibition of these pathways and symptoms related to Parkinsonism and increase prolactin. So the next hypothesis they came up with, which was a bit later. So here what they did was they saw that substances like LSD, which are hallucinogens. Obviously, as we know, hallucination is something that is not there. You see it, smell it, or hear it. Now, the LSD, it acts by being the agonist of the 5-HT2A receptors. Now, when they found out, they thought that serotonin could be another target for the antipsychotic drugs, right? So we have two targets. The first one is dopamine and the second one is serotonin. So let's move on to the antipsychotic drugs now. So the antipsychotic drugs, as you know, because they found dopamine first, so they developed dopamine antagonists, the first generation antipsychotics. They're also called the typical antipsychotics. As I mentioned, they are dopamine antagonists, particularly D2, the D2 receptor antagonism. Now, you can remember the typical antipsychotics by the mnemonic CFT-PMH. So, the first one that we have here is, from C we have chlorpromazine, and then from F we have fluphenazine, and then from T we have thioridazine, then thiothixine. Let's move on to the P. The P is prochlorperazine, and then we have pimozide, and then from M we have molendone, and the last one is haloperidol. Now, these are the first generation antipsychotics, also called typical antipsychotics, with D2 antagonistic action. Now, what about the second generation antipsychotics? For the second generation antipsychotics, we have the mnemonic A, B, C, then O, P, Q, R, and Z. So you can follow them alphabetically. So the first one is aripiprazole, and then you have brexpiprazole, then you have clozapine, olanzapine, then the next one is, from P is paliperidone, and then quetiapine, and then risperidone, and the last one is ziprasidone. Now, we haven't discussed the mechanism of action of the second generation antipsychotic drugs. So, as we know that the first one was D2 antagonist. These are also D2 antagonist, but the D2 antagonism is much less. And remember, there were two theories: the dopamine and the serotonin. So these guys, they are serotonin antagonists or the 5-HT inverse antagonist, particularly the receptor 5-HT2A. So they have D2 antagonism, but it is much less as compared to the 5-HT2A receptor antagonism, or you could call them inverse agonists. Now, the antipsychotics, they would they were so the antipsychotic drugs, the first generation and the second generation, even though I might discuss what are the indications, however, with regards to the exam, the side effect profile is very important, right? So we would dive into the side effects of the antipsychotic drugs right now. Now, they have been divided into the three categories. The first is related to the autonomic nervous system. So in the autonomic nervous system, you can expect the first one is the anti-muscarinic action, and then you can expect anti-adrenergic action. So the muscarinic receptors, they are present in the eye, the glands, the oral cavity glands, right, and then the gut and the urinary bladder. So the anti-muscarinic action would lead to, in the eye, especially the pupil, there would be loss of accommodation, and then the next one would be, because it's the oral cavity and the glands, they are having anti-muscarinic action. This would lead to dryness of mouth, and then the gut, which is constipation. Now, what about the urinary bladder? The urinary bladder contracts in response to the muscarinic receptors. So if you block that, you would end up with urinary retention. Now, we haven't talked about the anti-adrenergic action. So the anti-adrenergic action is the blockade of alpha 1 receptor. So if you block the alpha 1 receptor, which is present on the blood vessels causing vasoconstriction, if you block that, you would get orthostatic hypotension. Now, let's move on to the effects on the CNS. So, because we know that antipsychotic drugs are dopamine antagonists, so they would antagonize the action of dopamine. So, dopamine antagonism. Remember, in the earlier discussion, we were talking about the nigrostriatal pathway. That is where they would antagonize. So these drugs would lead to Parkinsonism. So in Parkinsonism, you have bradykinesia, pill rolling tremor, rigidity, right? So they could cause Parkinsonism. There are two more two more side effects related to dopamine antagonism. These are akathisia and then the acute dystonic reaction. So, what is akathisia? Akathisia is just restlessness. Someone who's taking antipsychotics is restless. Maybe they are tapping their feet, they are tapping their hand, or they are just tapping this pencil on their notepad. So this could be a sign of akathisia, someone taking antipsychotic, right? So akathisia is restlessness. Now, what is acute dystonic reaction? So acute dystonic reaction would be like someone having muscle spasm, especially torticollis. Their neck could be bent like this. I want all of you guys to remember this. Why? Because acute dystonic reactions can happen, and I've seen that. I remember there was one patient who was given haloperidol, the first generation antipsychotic, for delirium. What happened was he developed torticollis. He had acute dystonic reaction towards haloperidol, right? So acute dystonic reaction, there could be torticollis. Now there is one more side effect related to dopamine antagonism. Rather, I would say it is because of the super sensitivity of the dopamine receptors, and that is tardive dyskinesia. Now, what is tardive dyskinesia? Now, tardive dyskinesia is chorioathetoid movements. Now, this doesn't make any sense to anyone. I know that. Even when I read it the first time, chorioathetoid movement, nobody understands until unless you see it. So, patients with tardive dyskinesia can do like they could grimace like this, or they could pout like this. Funny, isn't it? No, you do not need to laugh when the patient does that. So there could be other symptoms of tardive dyskinesia, like they could be moving their face like this. So this is another symptom of tardive dyskinesia, and it is related to the supersensitivity of dopamine receptors. Now let's move on to the endocrine effects. The endocrine, as you remember, we also discussed the tuberoinfundibular pathway. In the tuberoinfundibular pathway, we saw that the dopamine was responsible for inhibiting prolactin release. So when you inhibit dopamine, you increase prolactin, right? So when you increase prolactin, what would happen? Increased prolactin decreases gonadotropin releasing hormone and decreases FSH, LH. Thereby, if it's a female, there would be amenorrhea. Right? So the side effects of most of the antipsychotic drugs have been discussed, right? So there is one more CNS side effect that we have left. Now, That effect is um, okay. So in the CNS you have histamine and the muscarinic receptors. So when you block that, you get sedation. You get sedation. So sedation could be another side effect for the antipsychotic drugs, right? So these are the general side effects of antipsychotic drugs. And one important point to remember here is that because second generation antipsychotics, they have less D2 antagonism, there is a less chance that they could cause Parkinsonism, akathisia, and acute dystonic reactions, right? So the extrapyramidal symptoms or the side effects, they are less with the second generation or atypical antipsychotics because they block serotonin more as compared to the dopamine. And the first generation one, they have more likely to cause Parkinsonism and the extrapyramidal side effects. So let's move on to the individual drugs. So there are certain drugs which have peculiar side effects. So the first one is chlorpromazine. It was the first antipsychotic drug, the prototype first generation or the typical antipsychotic. This drug has plenty of autonomic system related side effects, or the major ones. So this could be, as we discussed, loss of accommodation, and then there could be orthostatic hypotension, and then the next drug, you can add the other autonomic side effects to this drug if you want. Let's move on to the next one. Is another drug starting from C is clozapine. This clozapine, it has been found to cause agranulocytosis. So when you have agranulocytosis, the neutrophil count, it drops, and the ability to fight infections drops. So it is important for anyone who is on clozapine to be monitored for agranulocytosis. Their complete blood count, that is monitoring their total leukocyte count, is important. You get a baseline and then you follow them regularly, right? So clozapine has another side effect that we would discuss with olanzapine. Let's go to olanzapine now. The olanzapine, from O you can remember obesity, that is weight gain. Now both clozapine and olanzapine can cause weight gain. However, olanzapine can also cause it. So you could see metabolic syndrome, where you would get insulin resistance. Because it's insulin resistance, there would be hyperglycemia, and in metabolic syndrome you also get increased triglyceride levels, right? So with olanzapine and clozapine you would get weight gain and metabolic syndrome, and with clozapine particularly you would get agranulocytosis. Let's move on to the next important side effects of the drugs. Now We have discussed chlorpromazine, clozapine, olanzapine. Let's go to thioridazone. This drug can prolong the QT interval. Anything that prolongs the QT interval, they would lead to VT, and this VT is leading to cardiac death. This drug is not used nowadays. Why? Because it's very toxic and it's first generation antipsychotics, more likely to cause side effects related to antagonism, and it's cardiotoxic, so it's something that is not to be considered. So the next one is the ziprasidone. Now ziprasidone, it can also cause increased QT interval, obviously cardiac death. And haloperidol, the next one, it has increased risk of the extrapyramidal side effects. And what about fluphenazine? Fluphenazine has chances of tardive dyskinesia. Now, till now we have covered 1, 2, 3, 4, 5, 6, 7 drug specific side effects which could be asked in the exam. So you need to remember, for chlorpromazine, autonomic side effects; for clozapine, agranulocytosis; for olanzapine, obesity; and clozapine, olanzapine, both for obesity. Then thioridazone, cardiotoxic; ziprasidone, cardiotoxic; haloperidol, extrapyramidal side effects; and fluphenazine for tardive dyskinesia. Now, something about tardive dyskinesia. How would you treat tardive dyskinesia? So tardive dyskinesia can be treated because it's due to increased dopamine receptor sensitivity. Something related to dopamine should be the target. We are already giving antipsychotics, right? So what other thing can we give related to dopamine? So they developed a drug called valbenazine and deutetrabenazine. These are VMAT2 inhibitors. So what is VMAT? VMAT is vesicular monoamine transporter 2 inhibitors. So these two drugs have been used to treat tardive dyskinesia. And one important point is that if you have Parkinsonism related to the antipsychotic drugs and you cannot withdraw the antipsychotic, what would you use? Will you use levodopa? No. Why? Because you are already giving a D2 antagonist and you would add levodopa to the circulation, increasing dopamine, and this could worsen the psychosis if someone is already having psychosis, or let's just say they were stable yet they have Parkinsonism. You give them levodopa, you would precipitate psychosis in them, right? So for for people with side effects related to dopamine antagonism, we have we have anticholinergics. So if you see here, the dopamine and acetylcholine, they get imbalanced. If you decrease dopamine, acetylcholine increases in the brain, right? So you cannot do anything related to dopamine. As I said, if you give the person with Parkinsonism and he's on antipsychotic, levodopa could worsen the psychosis, right? So the only option left for us is the acetylcholine. So you give anticholinergics. So for drug related Parkinsonism, which are antipsychotics are causing, you could use anticholinergics, right? These are diphenhydramine, trihexyphenidyl, and then benztropine. So you can treat the side effects of the antipsychotics with a number of drugs if you are unable to withdraw the antipsychotic from the patient, because it is important for that patient, preventing psychosis, or you want to prevent the worsening of the psychosis in that patient. So this is where I will end the discussion on antipsychotic drugs. And I think if you have any questions, post them in the you can post it in the comment section. You can post it in the comment section, and this is where I will end this live video. I think this was a great learning experience for all of you, and we'll be back with another live video next month. And I hope you guys enjoy the case series that we posted yesterday, and keep learning and enjoy medicine, because it's an experience that not everyone gets to get in their life. So goodbye, take care.